All right, I'm here with Ryan. He is another one of my friends that I've never actually met, like Wes, but he's been following the podcast. Smart guy, flight medic. You want to do a quick introduction?
Yeah, my name's Ryan. First off, thanks for having me on the show. Never been on a podcast before, so apologies in advance for my terrible style. I work as a flight paramedic and a critical care ground paramedic down here in the Mid-Atlantic. Our base is unique in that we are an interfacility only aircraft, which, if you ask me, is the best kept secret in helicopter EMS. The patients are extraordinarily sick where we fly, and we get to see a lot of very different things that you might not otherwise get to see because we have a lot of patients that have been in another hospital for a couple of days. Um, we're doing a lot of sick ICU to ICU transports, as well as coming out of ER. So pretty good variety of cases. You know, what's different with doing the interfacility stuff is you see a lot of like late trauma. So in medical school, you're taught to take care of early trauma, the acute laying on the street phase, but now you're seeing people hours and days into their trauma, and the paradigms are a little bit different. And that's been something to get used to.
Yeah, what do you see for late trauma? Because a lot of the listeners who do pre-hospital may not see that. They don't see what happens to your multi-system trauma patient through 24, 48, 72 hours a week down the road.
Yeah, that's
How
a
was the
great question.
transition for you?
It was different, right? So, even so, I had done some trauma doing critical care ground, but it's a lot of local facility, sudden pickup trauma, shooting, stabbing. Patient gets dropped off at a community hospital and needs to get trucked down to the level one trauma center real quick. But for us, one thing you'll see is you'll have to get comfortable with pressors in trauma patients. That's controversial, but a routine practice where we work because you're 6-10 hours into your trauma course. Late hemorrhagic shock behaves a little bit like sepsis, and it's tough also when they're on sedative infusions and a ventilator, and it's like, are they bleeding? Is this neurogenic? Is this just from the sedatives? You don't quite know. It's different than just guessing hemorrhagic shock and usually being right like you have in the acute phase. And for the medical problems, the trolleys and things of that nature.
Yeah, you and I had a pretty good discussion on pressors in trauma, and we're talking about early trauma. My team is dead against using pressors in early trauma. I have mixed feelings. I tend to defer to our surgeons, but I have been on those scene calls for a trauma patient that is crashing and burning, and you give all the good resuscitation in the world, and I kind of sometimes I'm like, it would be nice to have a pressor, but then I think maybe I'm just generating a fake blood pressure. You had some great thoughts on this.
Yeah, so this is my take. Yeah, you shouldn't manage hemorrhagic shock with pressors. So if you have blood, blood is coming to my base this week. We're really excited for it.
That's
So thank you,
awesome.
thank you to everyone who put the work in and making that happen. The ground teams had it for a little bit also, so making a lot of progress there. So in general, you should not manage hemorrhagic shock with pressors. It's not a problem that hemorrhagic shock uh, pressors can't fix that. Where I think they come in is when you're doing airway management, you have to give drugs that directly cause vasodilation, right? So as we all know, all RSI drugs will cause hypotension to some degree, and I think that's a distributive shock the way I think of it. So you're not managing hemorrhagic shock with pressors. You're using pressors to manage the distributive state that you've caused with your own drugs, and that's where I think they tend to play more of a role.
Okay. So like what would an example be, from your practice?
I think a great example is you're transfusing your trauma patient or giving them fluids, blood, whatever. You get the map to where you want it, and then you give the RSI drugs. Their pressure dips post intubation. I think a squirt of epi or neo is totally appropriate because you're either dealing with the vasodilatory response to your drugs or the problems of mechanical ventilation, and so you're not managing their hemorrhagic shock. You're just getting them over the vasodilation that you yourself cause with the drugs.
Yeah. You mentioned mechanical ventilation and hypotension. Gwenny posted a thing on the Impact EMS Facebook thing about what's something that you've learned or you've changed your mind about in the past year. And I would say in this past year, I have really come to appreciate how the initiation of positive pressure ventilation can really drop your patient's blood pressure. So those not even just trauma, but any critical crashing patient that we're thinking about airway management, I was always laser focused on the induction agent dropping their blood pressure, which certainly is going to happen as you just outlined. But I never really truly appreciated the physiology. I would always hear like, oh, positive pressure ventilation will increase intrathoracic pressure. And I'd be thinking like, yeah, whatever. But no, that's really a huge thing. And that's something I've come to appreciate this year.
No, I totally agree. Especially as ventilators get smarter, you use in more of these PRVC style modes where the it's the initial pressure control breath it delivers is a really big breath. So like our team uses the Hamilton T1, um, and in those volume modes like CMV, SIMV, and ASV, that initial breath into the patient's a pretty big breath that it uses to start calibrating the algorithm, and
Sure.
that can cause a pretty tremendous intrathoracic pressure swing.
Yeah, definitely. So another thing that you have said that I really liked was actually we used the Hamilton T1 also at my flight job. So we had a Hamilton rep come he just like cold call dropped in on us and he was fantastic. He was talking about how much everybody is not how much everybody is, but lots of people are opposed to or hesitant to use ASV. And I told him your quote, and I gave you credit, that ASV is like autopilot on the helicopter. So you real quick want to discuss ASV and your thoughts on frankly why we should be using it?
Yeah, so a wise man once told me that you can put anybody on any mode. Ultimately, all ventilator modes blow air in and let it back out. That's all they do. Um, and I like to compare the ventilator to a helicopter. So we work with some professional pilots, and they fly. We're in a fairly technologically advanced DC-135, but they don't put all the fancy gadgets in these high-end helicopters to make it so that people who are less competent can fly them. To fly the EC-135, you have to start off flying the little Robinson that doesn't have all of the bells and whistles. So I think it's first important to understand that ASV is a great tool to enhance expert ventilator users be better at their job. It is not in any way, I don't see it as a crutch for not knowing how to use the ventilator, because much the same way that an autopilot will fly your helicopter right into the side of a building, it's still your job as the provider to know that ASV is doing the right thing. Um, we did some really good ASV education at work this year, and it appreciates way more variables than the initial description of the mode does. So just for anyone who's not familiar with the Hamilton T1 ASV, it's a proprietary to Hamilton. I don't get money from them. And it stands for adaptive support ventilation. And essentially you program in a minute volume goal for your patient, and then it delivers it in the most lung protective way possible. So instead of a tidal volume and a rate dial, you have a minute volume dial, and then within that, it appreciates things like expiratory time constant and other vent parameters to maintain lung protection. That being said, it's still important for you as the person using the vent to know that it's doing the right thing, because ASV will not work in all patients. Granted, they're few and far between, but I have encountered one of them, a patient where ASV would have not worked at all. And that was a really interesting case. So I think it's a great tool for experts to use, but I don't think you can use it to replace basic mechanical ventilator knowledge. The way I jokingly describe it is after a year of using the conventional modes really well, then I think ASV is great, because you really have to understand what it's doing.
Yeah, I love the helicopter analogy because I have read and I have heard from people like the guys from Riker Medical, a great vent book, by the way, free. Check it out. Those
I,
guys are freaking phenomenal. What were you gonna say?
no, it's a great book, and one of the only books that correctly describes SINV.
Okay, cool. Um, uh, I have heard from various people and read in Hamilton's own stuff that in patients who are pulling lots of minute volume, like your severely acidotic patient, for example, that ASV may not be the best to keep up with that. I asked that to the Hamilton guy, and he said that you really can match the minute volume even in those patients, and that's kind of a misconception. So you said one interesting case with the vent. What with ASV not working so well? What was your case?
So before I answer that, I will say to the metabolic acidosis part, yeah, that's an interesting comment because I got to live that firsthand. We actually went and picked up a freshly intubated metabolic acidosis patient. Um, ASV is not great to the extent that they have variable respiratory drive, but if they're just sitting there chugging away at 12 liters a minute, uh, if you're a Hamilton user out there, just pull up the ASV graph and it'll show you in real time what minute volume goal the vent has set, like 12 liters a minute or whatever, and then just look over to the left where you're seeing their expired minute volume, because it'll never take away minute volume. It'll never restrict the patient from getting what they want. It's just above the minimum goal. So say they're pulling 12 liters a minute, you have it set to 8, spin the percent minute volume dial until the goal matches what they want, and then they're being fully supported. Where it becomes troublesome is if they're speeding up and slowing back down, then that's when it chases.
That's exactly what he said. He said the patient it's not going to work on optimally is going to be the patient with ataxic respirations or Cheyne-Stokes respirations, your head bangers, stuff like that.
Exactly.
So
Yeah,
what
so
was your case?
let's talk about event case. So it was about 10:30 at night, marginal VFR conditions over the summertime. We were dispatched to take a patient out of a level 3 trauma center up to the local high-level trauma center where I work. Dispatch notes were a pedestrian struck, intracranial hemorrhage, and a tension pneumo with a chest tube. Not too many other details. A bit of a time constraint. So we are an IFR program, but this particular hospital does not have an IFR approach. So one thing that was in the back of our heads was we can do this flight, but if we have to leave IFR, we'd have to make arrangements to get over to the local airport to leave. Yeah, so we could do it safely, but it would have caused a bunch of logistical headaches, getting all of our stuff over to the airport and then tacking 15 minutes onto the transport. So because this is a real podcast for real people, not everything went completely perfectly. So
Never.
we get down there. The patient's laying in one of the trauma bays, clearly had a very festive trauma resuscitation.
I like that. A very festive trauma resuscitation. That's great.
He's breathing 40 times a minute, climbing out of bed, clearly in pain. He's on a fentanyl drip, and I think they discontinued the midazolam. So we walk in, hi, we're the flight team, nice to meet you. We put him back down with some ketamine. And I was serving in the crew role for my team. We have a fairly well-defined crew role, so my job would be to receive, report, make sure all the paperwork is done, while my partner does like monitors and devices, and then we kind of meet back in the middle and work on stuff from there. And so because we have to document a lot of prior to arrival stuff like drips and vents, we kind of run through the room, take a picture of all the vents, pumps, monitor, all that. But in truth of mission, you take pictures of those things, but you may not always appreciating in the moment what they're actually doing unless something's really jumping out at you. So we took a picture of the vent. Nothing really jumped out at us right away. We go about our day. The patient does have a right-sided chest tube, and that thing is like billowing air out of it. Like it's just a
Air leak
continuous
like a
flow of bubbles.
mofo.
No, so there was a leak, but it wasn't from any part in the tube. So we checked the tube, we chased the tube down, it looked fine. And everything was looking really good. And we put the patient on our vent, and we program him at 8 per kilo, so 560-ish a tidal volume. I was a fairly tall guy. Put him on pretty standard vent settings. And we're getting VTEs of like 80, 90, 100 mLs. The vent's freaking out. Low minute volume, low VTEs. Of note, earlier on in the call, we threw him on the end tidal right away, and we're getting like end tidals in the single digits. 8, 7, 9, with a kind of a lousy waveform, but he's got bilateral chest rise, and he's got a stat of 100%. So we're like, okay, this is definitely something that we need to look into, but it's not going to kill him right this second. So we throw him on the vent, and we're getting these lousy VTEs. And the real good takeaway points from this call are decision making and how to troubleshoot in a systematic manner, because that's when this call got a lot of play from our medical directors afterward, and that's what they really liked about this call. So to me, someone with lousy end tidal and a crazy low VTE, that's a displaced tube until I know for a fact that it isn't. So I'm thinking like this ET tube is probably sitting right on top of his vocal cords. The cuff's probably sticking out. The tube probably might be slightly dislodged.
And that is you went through a lot of technical stuff, which is awesome. But for the novices out there who are new to ventilators, what Ryan here is saying shows that he knows the basics. You always start at the patient first and then work your way back to the vent, because people want to start going to the vent, looking at the parameters, look at the patient first. And that is the basic. Is the tube in the right spot? Anyway, sorry to interrupt.
No, thanks. A great point. So we're getting these low exhale tidal volumes. We're like this thing. So my first move when our vent doesn't seem to be playing nice with the patient, while we troubleshoot, first they go back on the facility's vent. It's like, well, he was riding that vent before we got here, so put him back on their vent. And then when we look at their vent, we realize that it was doing the same thing. It's just that some of the alarms have been turned down. So we're like, oh, okay, he's got the same problem on this vent. So he's got chest rise, he's got a good sat. So next thing we go for is a chest X-ray, and because he had taken a few trips to and from CT, so we thought maybe moving around something got yoinked on by accident.
Did he have lung
Um,
sounds?
he did, yeah. So he was diminished on the right, but he had a
Sure,
pneumo, so it wasn't
absolutely.
not. I don't know how much value that is in this guy. We get a chest X-ray, and of course, there's air all over his chest, so it was kind of hard to read. But the tube was where it's supposed to be, right about. We had the RTs push it down like another half a centimeter just for good measure, because I don't, just in case, because he was kind of craning his neck. He had a long neck, so we push it down another half centimeter or centimeter just for good measure. We go back on our vent, same exact problem, and this is where your experienced ICU nurse partner comes into play. So I'm a paramedic by trade. I had always worked 911, a little bit of critical care paramedics. The way I describe it is at our program, the medics are expected to be competent in everything, but the nurses are expected to be comfortable with a lot of the devices that you as the medic don't see. And so while all of our medics could pass a check off on a chest tube, like we don't have the tacit knowledge you get from working with them every day. So like I was with an experienced cardiac surgery ICU nurse who this is like what they do every single day.
Awesome.
And was the one who was smart enough to clamp the chest tube. She clamped the chest tube temporarily. Shout out to my partner. Came in clutch. The VTE shot right back up. The vent looked great. And we're like, okay, so we're just losing a ton of air out this guy's lung. He's probably got a giant tear in his right lung. That's why he developed a pneumo. And that's where all of his air is going. But not
Did
wanting to
you
chase
think
numbers.
about a tracheal bronchial injury? Well, I guess you would have seen that on the X-ray.
Maybe I don't claim to be good at reading chest X-rays. I can find a big pneumonia and an ET tube. That's probably where it's supposed to be. That's probably the extent of
Gotcha.
my chest X-ray prowess. So what we did, so we clamped it, and that was our troubleshoot. But we crucially did not leave it clamped, obviously, because then he would develop a tension pneumo. So we're like, he's got some kind of pulmonary injury. Maybe it's lung parenchyma, maybe it's a bronchopleural fistula, something like that. But it was funny. We did a debrief with a couple local programs in this case, and one thing that someone pointed out is you might be tempted, like, well, this intervention made my numbers look really good, so let me continue doing this. But in this case, that would lead you to your demise because you would then develop a gigantic tension pneumo.
Sure.
So we re-released the chest tube. The volumes shoot right back down, but everything looked great when it was clamped. So we know all the equipment's where it's supposed to be. This guy just, doesn't have. He has pathology that the vent's just not going to play nice with. It's not going to, because we were in one of the volume modes, so the vent is heavily dependent on the feedback from the exhale tidal volume. And the way that this kind of worked in my head was I have my, my Hamilton flow sensor and my end tidal up at the tube, right? That's and if I were to splice one of those into the chest tube, theoretically, those numbers should add up to what I'm supposed to be getting, right? It's just the air is going into the lung. It's doing what it's supposed to do, because if it wasn't, he wouldn't have made it this far. This guy had been here for 6 hours. If that was truly the problem, we probably wouldn't have made it this far. So he's probably got good enough gas exchange. The air is just going out a different opening than it came in. So we left it in the volume mode. That way the vent babysits the tidal volume for me. And we realized that this is, our catchphrase is, this is just about as good as things are going to get. And then we decided to head out and leave. Over the course of the transport, this is where I think any other event would have not done as well, is that T1 has an incredibly powerful blower and was able to, my record, I think I had a 90% leak, and so it alarmed out as max leak compensation for the entire trip.
The Hamilton guy, he went over leak compensation with us, and one of the problems we always had on the Revel was that it couldn't keep up with patients that were on BiPAP that were super air hungry. And he was talking about leak compensation, and the leak compensation that the Hamilton has is just freaking unreal. It's like a freaking Maserati engine. And like you, I don't get paid by Hamilton. I wish I did, but anyway.
Yeah, so that was kind of the main takeaway from the call is the troubleshooting and systematic approach to the problem, right? Like not going head down, spinning vent dials, thinking that's gonna fix your problem.
Sure.
Because the conclusion we came to is this guy just doesn't have a condition that the vent's gonna play nice with. Like no ventilator is gonna work well with a person with a gigantic hole in their lung, bronchus, whatever. And this was our theory was confirmed is when this chart went through QA and we got follow up, we asked for feedback, and all the interventional pulm people and the critical care folks were like, well, you could do single lung ventilation or a bronchial blocker or VV ECMO, or it's like okay, cool. So nothing we could have done was
Yeah,
the takeaway.
exactly.
Like okay,
Exactly.
um there was some further discussion of like could we have considered a bronch and then a left main stem intubation 10 o'clock at night at a community hospital. That might not be the easiest. That might not be logistically that easy. And the one thing that our doc sort of came to the conclusion to was that if the local hospital's anesthesia and services wanted this guy, they would have done it by now. But it's like because on top of this, he's also got these various intracranial hemorrhages he's got to leave for. He's got to leave for that anyway. So we didn't branch out too far in that direction and start chasing. I don't know if they're rabbit holes or if we just didn't do our due diligence, but the general conclusion was the probably the best option was to realize the vet was doing good enough and to just leave.
Yeah. So I mean, everybody, especially paramedics who do critical care, we love our vent knowledge and we're vent nerds. You more than me, Riker Medical way more than me, but we do love to try to troubleshoot the vent, and we should. If a mode's not working for the patient, absolutely make them more comfortable, optimize ventilation, protect their lungs so they don't develop ARDS. But your case of the vent was doing good enough, it made me think of a 14-year-old drowning case that I had 2 summers ago. And we were going up and up on this kid's PEEP. I mean, he was just impossible to ventilate. We had paralyzed him to try to facilitate compliance as kind of like a last ditch thing. And we finally got him up to like 85%, but his end titles were super low because of how we were ventilating him. It was a hot mess. So we called our pediatric medical director, and she's fantastic. She was off duty, and she told us, she said, what was his pulse ox? We're like, well, it was in the 60s when we got to him at the bedside, and it's up to 85, and he's on like 20 of PEEP now. And she's like, 85 is probably the best you're going to get. We're like, what about the end titles and, the exhale tidal volume, all the parameters? And she's like, I don't care. 85 is as good as it's going to get. Take him. He needs ECMO. The vent is not going to fix this patient. And you touched on it. The vent is not going to fix the patient. There's all sorts of fancy vent modes, but ultimately we're just ventilating them till they can get fixed, treat the underlying problem. The vent's not going to fix anything.
Yeah, for sure. And I think if you're a ventilator nerd like myself, I think it's really tempting to want to fix everything with the vent because you think you know how to make all the numbers look really good. But a wise man once told me if you focus really hard on fixing this number, you're going to make that number worse in the process. Um,
That is
was
very good
a
advice.
wise man once told me. Um, and so for your case of hypoxia, like a really profoundly hypoxic patient, my general approach to that is once I have a strategy and the SAT is starting to tick up, that's when I start thinking about leaving because I can turn
Yeah.
up PEEP dials on the road. Like I can push pump buttons, vent buttons. I can do that while we're driving or flying around. I honestly need to do that at the bedside.
Yeah,
So
exactly. And that's exactly what we had done. We started seeing the pulse ox tick up, and my partner Serge and I were like, all right, let's move. And on the way to the helicopter, that's when I'm on the phone with the medical director, asking her, what the hell are we supposed to do with this poor kid?
no, that's awesome. It's yeah, I remember listening to that episode. That was a really interesting case.
Yeah, sad
But
case, but
for
uh,
sure.
every year we get some, especially you guys being around the coast. I'm sure during the summers you get them from sending hospitals.
Yeah, that and necrotizing soft tissue infections from shellfish.
Crabs, I
Disaster.
know, it's insane. People from other parts of the country don't appreciate it. But I mean, people may not know what the hell we're talking about, but we have a lot of crabs. Maryland and Delaware's got best crabs in the universe. and people pick them, they lacerate their finger, and what starts as a little sore rapidly transitions to necrotizing fasciitis.
Yeah, no, that's our bread and butter in the summertime. We do we'll take some necrotizing fasciitis off of probably your neck of the woods, out that way and south.
Yeah, yeah.
Because our main tertiary center we service is a soft tissue infection center, so they get sent there a lot.
Yeah,
But
was it you telling me that they have a necrotized? No, it was somebody else from your area told me that your big hospital has a necrotizing fasciitis specific program.
I don't know if it's specific to neck fascia. I know they specifically do soft tissue. I don't know if it's how specific
Okay.
it is, but they are a soft tissue infection center as part of their on the trauma side of that hospital.
Okay, I got you. Switching gears a little bit, you're almost done nursing school, right? Or you are done?
I'm done with the coursework. I'm taking NCLEX in a couple of weeks.
Okay. How, because I know a lot of medics want to go to nursing school, not me. How was nursing school?
It was unique. Um, you have the distinct disadvantage of having to get unprogrammed and reprogrammed, as opposed to if when you initially went to paramedic school, EMT school, or nursing school fresh out of high school, you didn't have any programming. You're a blank slate, so you can be programmed from day one how to do things in that way. And as a paramedic going back to school, especially I had been a paramedic for a little bit at that point. There's a fairly good bit of undoing to be done. So it was definitely different. So I went to a community college paramedic to RN bridge program.
Okay. Were the I know there's all the prereqs, but I'm sure it was a hell of a time commitment. What about the actual nursing classes? Did you find them difficult?
I found them difficult for different reasons than medic school. So medic school was difficult because a lot of times you had to get into a subject that frankly just don't find that interesting. Like there are some subjects in medical school I just didn't find interesting and had a hard time
Totally.
learning it because that's what paramedics have to know. Um, it's harder in that there's you probably a case in point would be some of the test questions. There's a lot more. You have to read into them a lot more. Paramedic school multiple choice question, and it's usually fairly apparent what they're getting at in the question. You just have to know which answer is correct. Whereas something about to get from something like when a patient ate or drank something to a bedside commode for fall protection, like there's a little bit more. You have to make a few more jumps to get to where the question's really taken you with this. Um, and a lot of it's just more it's more tedious to learn. So because they have to get paramedics only do a few things, right? We go to 911 calls, we fly to hospitals, and we don't do that many other things. They don't have to teach us how to do that many other things. Nurses can work anywhere, so you have to get a pretty broad education. So as a result, your example would be pharmacology, where you're getting a pretty broad spectrum of drugs that you may never interact with again, but you have to know at least all of them casually. And so it's more knowing a few things about a lot of different drugs as opposed to the smaller toolbox you work out of doing what we do. And it's just a lot of memorization in that respect.
Gotcha. Well, interesting. All right. You got anything else you wanted to talk about, or?
I don't think so. I really, really appreciate you having me on the podcast. I really enjoy going back and forth with you on the Instagram
Oh
DMs. I
yeah,
think
hell
we
yeah.
share a sense of humor in that respect.
Yeah, no,
Um,
definitely. Thanks for coming on.
so
Well, everybody, this has been Ryan, and I'm going to stop this, and we will keep talking for a sec here.